Normal adult hemoglobin ranges are 13.5 to 17.5 grams per deciliter for males and 12.0 to 15.5 for females. Normal hematocrit is 41 to 53% for males and 36 to 46% for females. Normal white blood cell count is 4,500 to 11,000 cells per microliter with specific differential percentages. Normal platelet count is 150,000 to 450,000 per microliter. Age-specific variations exist as children have different normal ranges. Physiological variations occur with pregnancy, altitude, and smoking affecting values. Example 1 shows iron deficiency anemia pattern. Laboratory findings include low hemoglobin, low hematocrit, and low mean corpuscular volume less than 80 femtoliters. Additional findings show low mean corpuscular hemoglobin, low mean corpuscular hemoglobin concentration, and high red cell distribution width above 15%. Peripheral smear shows microcytic hypochromic red blood cells, pencil cells, and occasional target cells. Clinical scenario involves a 35-year-old woman with menorrhagia and fatigue. Additional testing shows low serum iron, low ferritin, and high total iron binding capacity. Treatment response shows reticulocyte increase in 5 to 7 days after iron therapy. Example 2 demonstrates vitamin B12 deficiency pattern. Laboratory findings show low hemoglobin, low hematocrit, and high mean corpuscular volume above 100 femtoliters. Additional findings show normal mean corpuscular hemoglobin, normal mean corpuscular hemoglobin concentration, and normal or high red cell distribution width. Peripheral smear shows macroovulocytes and hypersegmented neutrophils with more than 5 lobes. Clinical scenario involves a 65-year-old vegan with peripheral neuropathy. Additional testing shows low serum B12, elevated methylmalonic acid, and homocysteine. Treatment response shows reticulocytosis in 3 to 5 days after B12 replacement. Example 3 illustrates acute bacterial infection pattern. Laboratory findings show elevated white blood cell count or leukocytosis above 11,000 per microliter. Differential shows neutrophilia above 70%, with left shift meaning increased band forms. Additional findings may include toxic granulation and DOLA bodies in neutrophils. Clinical scenario involves a 40-year-old with fever, cough, and lobar pneumonia. Platelets may be normal, increased, or decreased in severe sepsis. Treatment monitoring shows white blood cell count normalizes with effective antibiotic therapy. Example 4 shows viral infection pattern, like infectious mononucleosis. Laboratory findings show normal or elevated white blood cell count. Differential shows lymphocytosis above 50% with atypical lymphocytes above 10%. Additional findings may include mild thrombocytopenia with normal red blood cell indices. Clinical scenario involves an 18-year-old college student with sore throat and fatigue. Confirmation comes from positive heterophile antibody or monospot test. The course is self-limited with lymphocyte normalization over several weeks. Example 5 demonstrates chronic lymphocytic leukemia pattern. Laboratory findings show marked lymphocytosis often above 20,000 per microliter. Differential shows small mature lymphocytes and smudge cells on smear. Additional findings may include anemia and thrombocytopenia in advanced disease. Clinical scenario involves a 70-year-old with incidental lymphocytosis on routine complete blood count. Confirmation requires flow cytometry, showing CD5 positive, CD19 positive, CD23 positive. B cells. Staging is based on lymphocyte count, hemoglobin, platelets, and lymph node involvement. Example 6 shows immune thrombocytopenic purpura pattern. Laboratory findings show isolated thrombocytopenia below 100,000 per microliter. Additional findings show normal hemoglobin and normal white blood cell count and differential. Peripheral smear shows normal red and white blood cell morphology with large platelets. Clinical scenario involves a 30-year-old woman with petechiae and gum bleeding. Exclusion requires no other cytopenias and normal coagulation studies. Treatment response shows platelet increase with corticosteroids or intravenous immunoglobulin. Example 7 differentiates iron deficiency versus thalassemia trait. Both conditions show microcytic anemia, but different patterns. Iron deficiency shows high red cell distribution width, above 15%, low red blood cell count, and low mean corpuscular volume. Thalassemia trait shows normal red cell distribution width below 13%, high red blood cell count, and very low mean corpuscular volume. Peripheral smear in iron deficiency shows anisocytosis and poikilocytosis. Thalassemia shows uniform microcytosis, target cells, and basophilic stippling. Confirmation requires hemoglobin electrophoresis and iron studies. Example 8 shows acute leukemia pattern. Laboratory findings show pancytopenia or abnormal cell counts. Differential shows blasts present with more than 20% required for diagnosis. Additional findings commonly include anemia and thrombocytopenia. Peripheral smear may show auger rods in acute myeloid leukemia or lymphoblasts in acute lymphoblastic leukemia. Clinical scenario involves a 55-year-old with fatigue, bruising, and recurrent infections. This finding requires immediate hematology referral and bone marrow biopsy. Any blasts on differential need urgent evaluation regardless of count. Example 9 illustrates polycythemia vera pattern. Laboratory findings show elevated hemoglobin above 18.5 grams per deciliter in men or 16.5 in women. Additional findings show elevated hematocrit above 60% in men or 56% in women with normal oxygen saturation. Platelets are often elevated and white blood cells often elevated with left shift. Clinical scenario involves a 60-year-old with headache and pruritus after showering. JAK2 mutation is positive in over 95% of cases. Differentiation from secondary polycythemia requires erythropoietin level assessment. Example 10 shows malaria infection pattern. Laboratory findings show normal or decreased hemoglobin. Additional findings include common thrombocytopenia with normal or low white blood cell count. Peripheral smear shows intraerythrocytic parasites including ringforms and gametocytes. Specific patterns include Plasmodium falciparum showing multiple rings per cell. Clinical scenario involves a traveler returning from endemic area with fever cycles. Confirmation requires thick and thin blood smears plus rapid antigen tests. Treatment monitoring requires parasite clearance documentation on serial smears. Example 11 demonstrates HIV/AIDS pattern. Laboratory findings show lymphopenia especially affecting CD4 positive T cells. Additional findings include anemia of chronic disease and possible thrombocytopenia. Differential shows decreased lymphocytes with possible monocytosis. Clinical scenario involves a 40-year-old with weight loss, oral thrush, and recurrent infections. Monitoring requires CD4 count and viral load, which are more specific than complete blood count. Complications from opportunistic infections further alter complete blood count patterns. Example 12 shows chronic kidney disease pattern. Laboratory findings show normocytic normochromic anemia. Additional findings include normal white blood cells, normal platelets, and normal red blood cell indices. Pathophysiology involves decreased erythropoietin production by damaged kidneys. Clinical scenario involves a 65-year-old diabetic with elevated creatinine. Confirmation requires low reticulocyte count and low serum erythropoietin level. Treatment response shows hemoglobin improvement with erythropoiesis stimulating agents. Example 13 illustrates autoimmune hemolytic anemia pattern. Laboratory findings show decreased hemoglobin with increased reticulocyte count. Additional findings show spherocytes on peripheral smear and elevated bilirubin. Direct antiglobulin test or Coombs test is positive. Clinical scenario involves a 50-year-old with jaundice, dark urine, and fatigue. Warm antibody type involves immunoglobulin G mediation with possible complement positivity. Cold antibody type involves immunoglobulin M mediation with agglutination on blood smear. Example 14 shows myelodysplastic syndrome pattern. Laboratory findings show cytopenias in one or more cell lines. Additional findings include macrocytosis and dimorphic red blood cell population. Peripheral smear shows dysplastic changes in any cell line. Clinical scenario involves a 75-year-old with refractory anemia and macrocytosis. Bone marrow shows hypercellularity with dysplasia and possible ring sideroblasts. Prognosis is assessed by the revised International Prognostic Scoring System. Example 15 illustrates drug-induced cytopenias pattern. Laboratory findings show isolated or multiple cytopenias. Timing corresponds with drug initiation or dose increase. Common offenders include chemotherapy, antibiotics, anticonvulsants, and non-steroidal anti-inflammatory drugs. Clinical scenario involves a patient on new medication developing cytopenias. Mechanisms include direct toxicity, immune-mediated reactions, or dose-dependent effects. Management typically involves drug discontinuation leading to blood count recovery. Systematic approach to complete blood count interpretation includes several steps. Step 1 identifies which cell lines are abnormal. Step 2 quantifies the degree of abnormality as mild, moderate, or severe. Step 3 looks for patterns across different cell lines. Step 4 calculates absolute counts from percentages when needed. Step 5 reviews peripheral smear when clinically indicated. Step 6 correlates findings with clinical context and other laboratory results. Peripheral blood smear should be ordered in specific situations. These include unexplained anemia, leukopenia, or thrombocytopenia. Also, abnormal differential with immature or atypical cells present. Suspected hematologic malignancy requires smear examination. Microcytosis or macrocytosis without clear cause needs smear evaluation. Suspected parasitic infections like malaria or babesia require smear. Monitoring of known hematologic disorders benefits from periodic smears. Pitfalls and common errors in interpretation must be avoided. Ignoring clinical context often leads to misdiagnosis. Not calculating absolute counts from percentages causes errors. Overlooking platelet clumping leads to pseudothrombocytopenia misdiagnosis. Missing cold agglutinin effect alters red blood cell indices interpretation. Forgetting age-specific and pregnancy-related ranges causes misinterpretation. Failing to compare with previous complete blood count results misses important trends. Critical values require immediate clinical action. Hemoglobin below 7.0 grams per deciliter or above 20.0 needs attention. Platelets below 20,000 per microliter or above 1 million need evaluation. White blood cells below 1,000 or above 50,000 with blasts require urgent assessment. Neutrophils below 500 per microliter indicates severe neutropenia. Blasts on differential regardless of count need immediate hematology referral. These findings require prompt clinical assessment and appropriate intervention. Pattern recognition is the key to complete blood count interpretation. Microcytic anemia suggests iron deficiency, thalassemia, or chronic disease. Macrocytic anemia suggests B12 or folate deficiency, liver disease, or myelodysplastic syndrome. Leukocytosis with left shift suggests bacterial infection or inflammation. Lymphocytosis with atypical lymphocytes suggests viral infection, especially Epstein-Barr virus or cytomegalovirus. Isolated thrombocytopenia suggests immune thrombocytopenic purpura, drug effect, or early bone marrow failure. Pancytopenia suggests bone marrow failure, infiltration, or severe nutritional deficiency. Clinical integration determines appropriate next steps. Complete blood count abnormalities rarely exist in clinical isolation. Always integrate findings with patient history, physical examination, and other laboratory tests. Determine urgency based on abnormality severity and clinical presentation. Know when to refer to hematology specialist for further evaluation. Use serial complete blood count tests to monitor treatment response and disease progression. Remember, the complete blood count is a diagnostic starting point, not an endpoint. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.